My pleasure to welcome you here and to introduce Yong Kim, 17th President of Dartmouth College, as our next speaker in the Leading Voices series. Many of you are obviously familiar with President Kim's impressive accomplishments, so what I want to do is focus on the elements of his background that are most relevant to the discussion we're going to have today about healthcare. President Kim earned an MD from Harvard. He also earned a PhD in anthropology. Having gone through a PhD program and known the MD PhDs, those are the folks who are the ultra-marathoners. The regular folks are the marathoners. These are the folks who are truly amazing. But that interdisciplinary angle is, of course, crucial to recognizing that practicing good medicine is about more than getting just the science right. We must understand the people, the systems, the governments, the economics, and, of course, just about everything else that we study here, which is what a lot of our discussion is going to be about. President Jim Kim was a co-founder of Partners in Health and a former director of the Department of HIV/AIDS at the World Health Organization. In these capacities and many others, President Kim has been working on issues related to global health and social justice for more than 2 decades. In 2004, he was elected to the Institute of Medicine of the National Academy of Sciences, which is the highest honor, or one of the highest honors, in the fields of health and medicine. In 2003, he was awarded a MacArthur Genius Fellowship for his work in these fields. Throughout his career, President Kim has been heavily immersed in the academy. He has taught undergraduate and graduate courses in anthropology, social analysis, social medicine, global health. Before he made the wise choice to come to Dartmouth, he held professorships at Harvard Medical School and the Harvard School of Public Health. He's published widely over the last 2 decades in leading academic and scientific journals, ranging from the New England Journal of Medicine to Science. Yong Kim was born in Korea and raised from age 5 in Muscatine, Iowa, where he was valedictorian, president of his class, and quarterback on the football team. I'm convinced there were only like 3 people in the high school, and he was also in the band and caught his own passes, because otherwise it just wouldn't be possible. But on a serious note, let me finish by putting some form around what all of this means for Dartmouth, and particularly for sophomore summer. There are a handful of commonalities throughout Dr. Kim's career that will become apparent today. The first is that there's a clear and compelling recognition that practicing medicine is different than making people healthy, and that what we have to focus on is the latter. The second is a deep commitment to making the world a better place, and a recognition that as students and faculty, we should not merely stand on the sidelines, but that we should actually be part of implementing those solutions. And last, there's a belief that undergraduate education is enriched by engaging all of us with the world. That means bringing people here to campus. It also means taking the campus to the world and thinking deeply about the issues that affect all of us. That is the impetus for the Leading Voices series, and that is the impetus for our healthcare talk today. So with that, I'd like to welcome President Jim Kim.
Thank you. Thank you. Thank you. It's great to see everybody here today. So I'm going to try to quickly go through a lot of data. There's a lot of information in these slides. And healthcare is very, very complicated. I would argue that the modern hospital today is one of, if not the most complicated and difficult social institutions we've ever built. And the numbers and projections are pretty scary. We're at probably $7 trillion in healthcare expenditures today, probably 17 to 18% of GDP. But the prediction is that by 2080, we will be at 50% of our GDP will be healthcare expenditure if we keep going in the direction that we're going. So this is a problem for everyone. And I want to talk a little bit about how I got to this problem, and then different ways that Dartmouth College is, I'm very proud to say, playing a leading role in tackling the problems. So this is the kind of place I used to hang out in. This is Bobete, a small village in the highlands of Lesotho. And in that village, we built a healthcare system. This is a healthcare system where there's no electricity, there's no running water, but because we were committed to excellence in that particular area, this place has access to the internet. We have an electronic medical record because we found that it's cheaper and more effective to build healthcare systems in that particular way. So we've actually built them. But every time I went back and forth between places like this village and places like Harvard University or Dartmouth College, where we are now, with all these great resources that we had, we kept asking the question, why is it that it's always so difficult to provide low-cost, high-quality care? Now, the cost constraints in environments like that were intense, so I would argue that we were even able to be more creative than you would be in the United States, where there are fewer cost constraints. Everyone complains about cost constraints, but that is a place with cost constraints. The challenge of healthcare is so deep, so complicated, that it's getting so bad that we think that finally there will be enough pressure so that we have to act. Unfortunately, for about the last 20 years, we've been saying that. Now the pressure is so intense that certainly we're gonna start to be serious about reforming the healthcare system, and we're beginning to get there, but that we're not quite there yet. The reform of the healthcare system needs great champions, and the block in the middle about healthcare demanding an academic partner with a new vision is green for a reason. Right? And solutions will require interdisciplinary approaches. There's no one solution or no one discipline that can tackle effectively the enormous complexity of the American healthcare system. Think about a modern teaching hospital today. You've got sick people. You've got medicines. You've got nuclear medicine. You're irradiating people. Let me move this down a little bit. There are so many complexities, and within each hospital, you have very, very complicated social hierarchies that vary from hospital to hospital. So it is an incredibly complicated system that requires a reimagining, and that requires people from many different disciplines. Now, this is what healthcare expenditure is going to look like. That's how quickly it's going up. So President Obama, elected in 2008, by 2016, he may witness an almost doubling of healthcare expenditures for the U.S. if costs continue to rise at the current rate. And you've probably heard, but of the 31 OECD countries, the U.S. spends more on healthcare than all the other 30 countries combined. Right? All the other 30 countries combined. Now, you'd think that, that this would lead to great outcomes. Well, it turns out that we know we can do a lot better, because a lot of the most important health problems on the right, you see that the attributable deaths, obesity, and smoking have a huge impact. So in other words, there's tremendous progress that we can make without even spending a penny on healthcare delivery by focusing on prevention. So there's a lot that we can do to make health in the United States better. Now, if you look at where we rank among the OECD countries, how well are we doing in healthcare? Look at obesity. U.S. is 30th, the worst in all the OECD countries in terms of obesity. The only place where we really shine, where we're number one, is the number of MRI machines per million population. Right? So, infant mortality, basic indicators of health, not only are we spending more than all the other OECD countries combined, the outcomes are really not that good. In fact, pretty poor when you think about what we're spending. So the correlation between spending and health outcomes is a theme that will come up over and over again in this talk. So one of the questions is, well, you hear it here. You'll hear it right here in New Hampshire. If they would just pay us a little bit more, things would get better. And so that's a question. Is that the issue? Do we need more money? Now, this is a complicated map, and all it shows you is the variation in Medicare reimbursements per patient in a particular area. And it varies tremendously from $5,000 up to $17,000. So there's a threefold difference in different referral zones in terms of how much is paid to any individual referral zone for Medicare. A threefold difference. Now, one would hope, well, and the people who are involved in those systems often argue, well, the reason that we're so much more expensive is because we do better care and our patients are more complicated. Unfortunately, the evidence is not very good. The higher spending regions perform worse on standard quality measures, had physicians who reported greater difficulty in ensuring continuity of care, and had patients who were less satisfied. So less satisfaction, poor continuity of care, and just not good quality. And look at this plot. This is, on the bottom axis, how much states spend, or how much states are reimbursed for Medicare. And then the other axis is where they rank. So this is New Hampshire up here, pretty darn good. We're at the top in terms of overall quality, and we're really not down here in terms of cost. Louisiana, Texas, California, Florida, very high rates of spending, but actually very low in terms of quality indicators. So in other words, there's really not a very strong connection between the amount of Medicare reimbursement and the quality of care. Now, there was a very now famous article written by a former colleague of mine, Atul Gawande from Brigham and Women's Hospital, and it was called The Cost Conundrum. And he looked at one of the places in the country that had the highest Medicare reimbursement rate, and that was McAllen, Texas, $15,000 a year. And in that article, he wrote, "A medical community came to treat patients the way subprime mortgage lenders treated home buyers, as profit centers." And he went into the community of McAllen, Texas. It was in the New Yorker, and he asked doctors, did you know that this was the case? And mostly they didn't, because that's not something that's on the front page of the newspapers. Here is our Medicare reimbursement per person. But they were at 3 times La Crosse, Wisconsin. And the argument, of course, was our patients are sicker. And so he did a comparison between McAllen, Texas, and a town in Texas just up the road with almost exactly the same population, almost exactly the same population and indices in terms of their health status. And just up the road, there was a town that had a reimbursement rate that was half of McAllen's. Right? So it wasn't the complexity of the patients, but they had gotten into a system, and Atul argued that it came to be kind of there was a tipping point. Enough people were aggressively treating patients, sending them for MRIs, sending them for unnecessary procedures, and it just took over the whole area. Now, La Crosse, on the other hand, Jeff Thompson, who is the head of one of the important healthcare systems there, they, like, for example, the Mayo Clinic, and the area around the Mayo Clinic in Minnesota has about the same Medicare reimbursement because they think about the population health. They think about everyone's health from a public health perspective as opposed to thinking only about how much money they can spend. So there are just examples like this all over the country. Now, one of the things that we're doing here at Dartmouth, and this is Jim Weinstein. Jim Weinstein is currently the president of the Dartmouth Hitchcock Clinic, and truly one of the leading figures in healthcare delivery today. So a bunch of different hospitals came to Jim and asked him to start what they're calling the High Value Collaborative. It's a fantastic program. The best systems. Denver Health has a very large percentage of their patients on Medicaid, which of course reimburses at a relatively low rate, and a lot of the other patients are uninsured, and they are making a margin. In other words, they're doing really well on that kind of financial structure, a fantastic system. Cleveland Clinic, again, a paragon of effectiveness and quality. Mayo Clinic, Intermountain Healthcare has become very famous because Brent James, who, by the way, spent time here at Dartmouth and is a very close colleague of our colleagues here at the Dartmouth Institute for Health Policy and Clinical Practice. Brent James, out in Utah, has built a fantastic system where he has built in measurement and protocols in a way that no other hospital in the country has, Intermountain Healthcare. And at the center of it is the Dartmouth Institute and Dartmouth Hitchcock. We're sort of anchoring this high-value collaborative, and the idea is that across these healthcare systems, we're going to figure out who does a particular procedure the best. For example, Intermountain has a fantastic program for diabetes patients. And so the idea would be that you take and you find the best, lowest cost, highest quality intervention, and then across the health systems that are participating, we all adopt that approach. We all take as a target that many procedures. And this has the potential, we think, to really have a great impact. And let me show you how. First of all, the Wall Street Journal was very excited about this particular collaborative. Don Berwick, who is now currently the head of Medicare and Medicaid, literally a week before he was named into that position, was up here talking with us. And Don really feels that it's collaboratives like this who make the point that if you look around, find out how you can do it at low cost and high quality and spread that across different healthcare systems, that there is magic in that process, especially if we can do it much more broadly. So there were 5 hospitals, but these are all the other hospitals and healthcare systems that now are just about ready to join. So we're going to expand quite dramatically, including the Department of Defense, with a $12.6 billion a year spend, has expressed strong interest in joining this collaborative. And so if all these systems do end up joining, and we think they will, our collaborative will represent 50 million covered lives. If we can make this work, the impact, I think, will be pretty profound. Now, I apologize for the people who are not used to reading graphs all the time, but this is a scatter plot of the number of back surgeries per 1,000 population that are done, and originally it was for California. So from San Francisco up to Stanford, the rate of back surgeries per 1,000 population ranges from 2 in San Francisco all the way up to 5.4. But you can see that there are places where they're doing 9 back surgeries per 1,000 population. So there's a more than 4-fold difference in the number of back surgeries per population. And what do people tell you if you go and ask them in those regions? Well, we have sicker people with worse backs, right? Every time we've looked at that argument, it's mostly not been true. It just happens to be that they do more because you get paid for doing back surgeries. And so we asked the question, what if, and Dartmouth's right, so Jim Weinstein is a back surgeon, and he developed a system where we only do 2.2. So we're among the lowest. And why is that? Because one, if you talk to people, and you use a system called shared decision making, if you talk to people and really understand what they want out of a particular procedure, the vast majority of the people who go into surgery in those 9 and 10 per 1,000 population areas actually don't want back surgery, but need to have the implications of back surgery explained to them fully, and a lot of people don't take the time to do it. Shared decision making is something that we invented here, that we use at Dartmouth Hitchcock Medical Center, that really elicits what patients want, and therefore gives them the care that they want and no more, and need and no less. That's the slogan that we use in shared decision making. So the question is, Dartmouth does 2.2. Fantastic outcomes. Jim really tries to operate only on those cases in which we know that an operation will help. And so what would happen if all the hospitals in the collaborative, instead of being at their varied rates, came down to our rate? So Dartmouth is in the low end, and if you took all the hospitals that are potentially going to join our collaborative and change them over from as high as 6.6 per 1,000 to just 2.3, which was 2000. 2.2 was 2002, 2003 data. This is 2007 data. If you brought them down to 2.3 operations per 1,000 population, just those systems we're talking about would save $54 million in terms of Medicare costs. If you extended that to the entire country, if we could get everyone down to 2.2 or 2.3, which we think is about right, the overall savings over a year would be $580 million. Now, that's just for Medicare reimbursement. If you included the private systems, and just think about it, how many other problems are there in which we're very likely utilizing? There are a lot. So this is one of the commitments that we're going to make across the collaborative, that when somebody's doing it really well at low cost with great outcomes, we're going to try to replicate it throughout the entire system. And it's years of work of Jack Wenberg and the people at the Dartmouth Institute that's put us in this position to do it. Because we've had a leadership role for so long, we feel that it's an absolute, it's almost an ethical issue. We need to stay in this game, and we need to play this kind of role to help bring about these kinds of savings, but also prevent unnecessary surgeries and begin the process of moving toward healthcare expenditures that make more sense. Now, one of the things that's really striking is that companies are looking at, AT&T has already booked $1 billion in increased expenditures with the new healthcare healthcare law that's been enacted. And so if you look at, I'm sorry it's so small, but if you look at their cost, so to provide medical care to active employees and retirees, the cost to the company is $4.7 billion. But if they opt out and pay the penalty for not providing those benefits, the cost is $600 million. So companies are seriously thinking about opting out, a lot of them, and they finally admitted that they're thinking about it. just opting out of the system altogether and not providing health insurance for their employees because it's much cheaper to opt out than it is to actually pay the cost of almost $5 billion. This would fundamentally change the structure of American healthcare. So I hope it's clear that there are lots and lots and lots of reasons why we need to take this on. So this is Jim's slide. Years ago, at a group of physicians at the Harvard School of Public Health did a study on the error rate in American hospitals. And they came up with a number of 3%. So 3% of all procedures, all interventions are plagued with errors. 100,000 deaths a year in healthcare settings from errors, from mistakes. Right? So two colleagues of mine, close colleagues and friends, actually Howard Hyatt was the head of the study, and Howard just received a honorary degree from us this year. And in presenting the study, the reactions were really quite amazing. A lot of the physicians said, 3%? That's not bad. How many would get on a plane that had a 3% error rate? Right? Error rates in other industries are far, far lower. 3% is an extraordinarily high error rate. And there has been a tremendous movement, a very interesting movement. Atul Gawande, again, who has been among the most brilliant and influential writers, writes about checklists. And he writes about what what flying was like before pilots used checklists. There was a brand new Boeing airplane that was built, and there was a big production about launching this first Boeing airplane. This was decades ago, and this was prior to the era of checklists. They had all kinds of media there. The pilots got in the plane went up, and it crashed. And so checklists now, if you've ridden on airplanes and seen in the cockpit, they're always going through a laborious checklist to make sure that all the instruments are working, and it's improved safety enormously. A physician, Peter Pronovost, showed that if you go through a checklist of 6 different very simple items as you're replacing intravenous catheters, intravenous lines in the ICU, you can lower the infection rate from those line placements, not 10, 15, 20, 50%. You can lower them to 0. He lowered the infection rate to 0 in a hospital at Johns Hopkins, and they said, well, of course, because that's Johns Hopkins, can you do it elsewhere? So he did it in Detroit. Same thing, lowered it to 0. And so we're arguing that why don't we use checklists in healthcare? And it's been unbelievably difficult to implement. Simple thing like 6 things that you should always do before you place an intravenous catheter. Very difficult to make that happen. And so Jim's argument has been we're flying without instruments. We're not doing checklists on the one hand, but we also really don't have good ways of knowing whether a physician is really good. You can't find things like death rates of surgeons. It's very difficult to know for any of us whether a surgeon is really good because we don't have the outcomes data that we need to be able to tell where we're going in healthcare system. Modern cost accounting, Professor Robert Kaplan at the Harvard Business School has recently become very interested in healthcare. And his great surprise was that while modern cost accounting has been implemented in just about every industry, for the most part, it hasn't been implemented in healthcare. Most healthcare institutions don't actually know their costs. They know their charges, and they know their they know their payments, but they don't actually know their costs. And they certainly don't know the cost of an entire treatment. What's the cost to treat diabetes in your institution? You've got to then look at all the different steps that go into it and have a way of measuring this over time. Most hospital departments are not held responsible for keeping at a very certain cost. They're mostly measured on revenue targets. So we've got a long way to go. We've got to develop the instruments. We've got to use the instruments. We've got to use things like checklists. The healthcare airlines has a long way to go. And many of you have seen this before. I think that a fundamental issue is that we're not investing in the study of what we're calling healthcare delivery. We spend roughly $30 billion a year through the National Institute of Health, and then there are other private foundations to understand basic science and clinical science. Here at Dartmouth, the Dartmouth Institute, we've done a huge amount of work on evaluating outcomes generally, like through Medicare records, not in terms of individual patient outcomes. But we feel that the fundamental missing piece is that we need a large group from multiple disciplines to tackle the incredible complexity of delivery. We need outcomes researchers, economists, and others to figure out how to actually measure outcomes. We need systems engineers. Systems engineering is a discipline that when it has been applied to things like waiting times in hospital emergency rooms, had almost miraculous impacts. And when I talk to the engineers, we have a few at Thayer who are working right now with multiple hospitals. They tell me this is really simple stuff, but if you apply it to some hospital systems, the impact is just enormous because we don't have systems engineers on a regular basis, working in most of the hospitals. This is an interdisciplinary, multidisciplinary approach that needs to be built. So last year we established the Dartmouth Center for Healthcare Delivery Science. Since then, about 6 other higher education and other institutions have built their healthcare delivery science centers. And I'll talk a bit more about what I think is really needed. So this is our institute, and here's what we think it can do. So we need the best thinkers, people like Peter Pronovost and Atul Gawande, people who've thought a lot about healthcare, have a lot of great ideas, to work with the best doers. This is going to be a very applied field. We're not going to be able to just publish papers and think that those published papers will spread good ideas and everything will change. There has to be a constant interaction between those who are actually delivering care and the researchers and thinkers who are actually implementing in the front lines with the best communicators. The issue here is spread. The diffusion of innovation is a topic that has been around for a while, and understanding how great innovations diffuse is an important part of a lot of different industries. We need to find a way that when we find interventions that seem to work in specific contexts, we've got to find a way to communicate that and help hospitals all over the country implement. Now, the research, first of all, models. What are the models that work? What is it about Intermountain Healthcare that makes it so successful? We're just now beginning to do the observational phase of the science, write the case studies. What is it about Intermountain that seems to work? Is it the people? Is it the methods? Is it the measurement? How does it actually work? We still haven't got the case studies that tell us why the best systems work so well. Methods. We're going to have to think of new methods. Economists, especially in developing countries, are utilizing a method called randomized evaluation, where they take major programs and roll them out in large areas, but they do it in a stuttered fashion. One group gets it in the first 6 months. The other group gets it 12 months later. But they measure outcomes across all the groups. And so that in the stuttering of the rollout of a program, you don't get true randomization, but you get a really good idea about the impact that particular programs have. Those new methods we really need to incorporate, but there's really not a major governmental or funding institution that funds that kind of research. And metrics, it's a constant effort to figure out how to measure where we're going, whether performance is really what we think it should be. Now, I showed you this slide just for a very simple reason. This was one of the slides I was thinking about showing you, and I decided against it. And then my son last night walked in the room, and he said, "Dad, that's a fake." So what do you mean it's a fake? Well, those are 2 different photos. And I said, "Well, how do you know that?" He said, "Well, there's a line through the photos, and there's no way that you could enthrall an audience like that." Right? So I told him I'd tell you this, and he was very embarrassed. But this is our group, 50. We brought in, so that the Healthcare Delivery Science Group, working with Tuck School of Business and the Dartmouth Institute, for the first time, as far as we know in history, brought together a group of 50 healthcare practitioners. These are nurses, physicians, social workers, lawyers who run healthcare systems, MBAs who run healthcare systems. And over at the Tuck School of Business, we are taking them through the first of its kind master's program in healthcare delivery science. And so because they're actual practitioners, there's no way that we could take them out of context and keep them here at Dartmouth for 18 months. So they'll spend a total of 6 weeks on campus, and the rest of it will be done online. And we've worked really hard on getting great online materials. We had a test run. We took the online materials and did a test run with some of the folks from Dartmouth Hitchcock Medical Center. And we know we can continuously improve them. But there were some magical moments when our great strategy professor, Vijay Govindarajan, began talking about how different other industries had tackled problems very similar to the ones that the healthcare system has. You could just see light bulbs going on, people's jaws dropping. And after his talk, they began to adopt his language about strategic thinking coming from other fields. We had our Dartmouth Institute outcomes researchers going through data that, again, broke apart many of the myths that we hold in healthcare. And that conversation has just been stunning. These are people with an average of 23 years of experience in healthcare. And so they know what is wrong with the system. And each of them are going to take on a major project to improve healthcare back in their own regions. And so this is part of the process of creating a new kind of healthcare professional who can think across many different disciplines and have in their head at any given time how you can do things better. You know, when I graduated from medical school and went into my first year of internship, first of all, the hospitals are incredibly complicated. You're walking around, there's so many things going on, so many moving parts. And I went into that hospital setting for the first time thinking the system is like this, and it was really, what's the right word, chaotic. And in the evenings, what would happen is that the person on call would accept patients, sign-outs. You know, we would go and because there was a group of 4 of us and we were on call every 4th night, the other 3 physicians would do as much work as they could on their patients, and then at some point would come to me and say, okay, I've got 6 patients, and I would follow them overnight. And sometimes the sign-outs were really great. I understood exactly what I was supposed to do. Sometimes they weren't. The quality of information passing between one doctor and another, which is literally vital to the health and survival of these patients, was so haphazard. Some were good, some were not, and I kept thinking, well, but there's no way to do it better. And then, you know, we began hearing in this class about companies like Southwest Airlines, who have just stunningly well thought out and intricately choreographed information exchanges. And so this is one of the areas that we need to work on. But what we need now are medical students who graduate, who walk into hospital thinking, you know, this system works like this, but, you know, Theta Care and Intermountain do it differently, and Mayo does it differently, constantly entertaining in their own minds that there are better ways to do this work. That is what a field would look like. And I'm very proud to say that our medical school, Dartmouth Medical School, will begin teaching healthcare delivery science from the first year of medical school. We're applying the concept in other areas. And so we've just launched the Learning Collaborative on high-risk drinking. And this is a scene from the meeting that just happened a couple of weeks ago. And it was really interesting. And I'm told by people, again, at the National Institute of Health that this is the first time anything like this has happened. And the principles upon which this is based is very simple, very straightforward process improvement principles that have been utilized in car companies, in other aspects of industry. It's also been used in some of the best healthcare systems where people share insights about a particular problem, figure out ways of doing short cycles of change, measuring whether they're an improvement. It's the classic Six Sigma, the G program is the Six Sigma program, just the classic process improvement, what the Japanese called Kaizen, you know, continuous quality improvement. And we've treated all 32 schools that are part of this learning collaborative as individual units that are working as a team, sharing insights to try to tackle the problem of binge drinking. 5 of the 8 Ivies were there. We had some great institutions from all over the country. And as they walked around the room looking at what the other institutions were doing, to a person, every person I talked to during that meeting said, you know, we thought we knew what we were going to do, but my God, Duke had a great idea, or Frostburg State had a great idea. And the learning that's happening now between these groups, we hope will have a major impact on both reducing harm from binge drinking, which is the most important thing. We want to reduce deaths, reduce hospitalizations, and lower the overall drinking age. And so we see this as part of our overall healthcare efforts. My goodness, high-risk drinking is such a problem in just about every campus in the United States that we hope what we can do is, with this methodology that, again, is beginning to be used in healthcare, have an impact on this difficult problem. I show this slide just about every time I talk. And once again, I find it to be very useful. You know, what do we need to do to fix the healthcare system? It's so complicated. The one thing I'm absolutely sure about is that there's not going to be one single answer. And anytime you hear someone say, it's simple, just change the incentives. Well, let me tell you, we've changed the incentives on many different occasions, and what happens is hospitals and physicians find ways to game the system and get around the incentives and do the same thing as they did before. Or do different things that are higher paying that they didn't do before, but they'll find ways to get around the system. I really believe this idea. I believe, when John Sloan Dickey said this, after, the year before, he had been named president of Dartmouth College, and he had, 2 weeks after he defended the U.S. government as head of public relations in the State Department, 2 weeks after he defended the U.S. government for dropping nuclear weapons on Hiroshima and Nagasaki, he was named the 12th president of Dartmouth College. And he said this, of course, at the 1946 convocation, his first convocation. Policy change is really important. Research and grand experiments where we really look at different kinds of healthcare solutions is really, really important. I think there needs to be a frankly, presidential effort. I think President Obama needs to stand up and say 50% of our GDP by 2080, 4.4 trillion by 2018. This is a huge problem. This is going to break the bank of the U.S. government. This is going to make industries non-competitive. We've got to do something that really works. And I think that ultimately it's the better human beings who are walking around with models of improvement in their minds, knowing how well other systems have been able to solve complicated problems. It's those better human beings that ultimately will solve this problem. 50 medical doctors came here 2 weeks ago, very interested in quality improvement, run systems, very sophisticated, average 23 years of research. And what we found is that they were not walking around with those models in their heads. We gave them some of them, and we're going to give them a lot more over the next 18 months, and we think that's a great start. But medical students, public health students, MBAs, lawyers, I think there's no lack of practitioners who need these models. In terms of research, we need, for example, new ways of imagining healthcare. Susan Sontag wrote a book called Illness as Metaphor when she had her own bout with cancer. I think that one of the problems is that in terms of imagining health, we do equate health with healthcare. And if we can reimagine health in some fundamental way with people from all over the different academic institutions participating, we have a chance to make a huge difference. Let me give you one example of an approach that gives me great optimism. Again, Atul Gawande wrote in The New Yorker about what he called the hotspotters. And the first case that he talks about in this article is Dr. Brenner, who became very interested in the poorest patients who got the poorest quality care. And he found out that in the town of Camden, New Jersey, 1% of the patients, the highest spending patients, the highest cost patients, accounted for 30% of the entire healthcare expenditures. So he asked, can I have a practice that just focuses on that 1% of patients? And so he enrolled just a small number of that 1%, but he was able to decrease their hospitalization costs, for example, by 60%, just with very simple interventions. And what were those interventions? Going to actually see the patients in their home, getting some sense of what the patients' lives were like. And it was him at first, but then it became nurses and then social workers. And then the other example that he provided, run by Rashika Fernandopoulos and his colleagues in Atlantic City, took on the highest spending group of patients among the Atlantic City casino workers. Again, what they did was a couple of physicians, more nurses, and what they called health coaches. But these were basically people from the communities, and often these were communities that didn't speak English as a first language, who spoke the language and who would go and actually visit the people on a daily basis. Some of the results were stunning. Ruchika visited Dartmouth, and we're really thinking of implementing some system like this here in the Upper Valley. And he told us that they had 600 diabetes patients. Every single one of them was seeing a specialist, an endocrinologist. And the average hemoglobin A1C, which is a measure of how well your blood sugar has been controlled, was more than 15, which is very high. Your target is around 6. And over that time period, what happened to those 600 patients is that they went from 600 seeing an endocrinologist to 6 seeing an endocrinologist. The rest were being managed by primary care physicians. And the average hemoglobin A1C dropped to around 6, if I remember correctly. Don't quote me on these numbers, but that was the sort of drop that they had. And so immediately, they saved a lot of money for the system. But what is really exciting is that if you manage diabetes that much better, that means down the line you have fewer peripheral vascular problems, fewer patients becoming blind, fewer patients developing heart disease. And so Atul, again, who's a very good friend of mine, said, this is a great, new, innovative idea. Well, we've called this community health workers, and we've been doing it for 30 years in Haiti, and it's exactly the same thing. It's the notion that you have to task shift. You have to take things that doctors normally do and move it to nurses, take the things that nurses do and move it to community health workers. But most importantly, ultimately, the most important task shift is to the patient. Patients actually feeling like they're in control of their health, not just going to the healthcare system when things fall apart. Now, the reason it gives me so much hope is that it suggests to me that healthcare, whether it be in Lesotho, the first picture I showed you, or in places like Atlantic City, or right here in the Upper Valley, that there are some fundamental human constants that we can learn from Lesotho to Atlantic City to the Upper Valley that will be the foundation of this new field. Pretty straightforward things. What's the meaning of an illness to a patient? How do you organize the care of a patient so that you have somebody with them almost every day helping them make better choices? That's what they did. Some of the health coaches actually went shopping with the patients. And I think that not only is that a more humane way to deliver health care, but because healthcare costs are going up so much, and because we know that those things are now saving us money, we may be moving in a direction where we'll have great health care. Some of you have seen this picture before. This is Joseph June, who came to our clinic in Haiti, suffering from both tuberculosis and HIV. And with the help of a community health worker who visited him every day to make sure that he would take his medicines, and it's not easy for a person living in rural Haiti to take a pill in the morning and a pill in the evening, so we hired one of his neighbors in the village to work with him every day to make sure that he had everything he needed to take his pills. And a few months later, he looked like this. The Lazarus effect of HIV treatment that we don't see anymore in the United States because we never let people get that sick. But in 1996, when these treatments first became available, those are the kind of transformations we've seen. And so how exciting to think that the same thing that worked in rural Haiti so effectively has now been shown to both lower costs and improve quality in a place like Atlantic City and Camden, New Jersey. It's a huge problem. It's a huge challenge, but it's one that I think will be a problem for everyone in this room for the rest of their lives. Healthcare, the cost of it will be a problem for every one of us for the rest of our lives. And I can't tell you how proud I am to have the chance to work with fantastic faculty here who are going to make a great, great difference. Thank you very much.
As we've done in the other events, we have some time for question and answer, so Dr. Kim has generously agreed to answer questions from the group. I'm going to start, and I appreciate the talk, and Dr. Kim came and spoke to my class earlier in the afternoon. I'm going to give you a series of words that didn't come up in your topic, in your talk, and you tell me what they have in common. Congress, Obama, Sarah Palin. This is all obviously very political. Big player in the healthcare debate is Congress. The first question is a very serious one, which is to what extent has or will the Obama healthcare changes affected, in a positive or negative way, all of the things that we need to focus on to deliver better health?
You know, one of the things I've been concerned with my entire life is increasing access to healthcare. So I think in terms of increasing access to healthcare, the new healthcare law is just fantastic. It's an important step. But many of us were very disappointed in that there was not the kind of aggressive measures on cost and quality that we would have liked to have seen. So I've said this now a lot, and I said this to Secretary Geithner when he was here. I think that this calls for a major effort. I mean, if these numbers are true, and if anything, over the past 30 years, we have consistently underestimated the rise in healthcare costs. Every time we've done it, if you look back, we've underestimated the rise in healthcare costs. So the numbers I've given you may even be underestimates. And why is that? It's very simple, because if there is something new that you can do for a loved one who's sick, why wouldn't you do it? Everybody in the world would say, do everything for my mother or do everything for my father, and we're not well equipped to be able to make the kinds of good decisions and get at the values, for example, through shared decision-making, which we've done at Dartmouth Hitchcock so well, so that the costs just don't go up like that. So my own personal views, if you look back, when President Kennedy said we're going to get to the moon before the end of the decade, and he sort of rode herd over that whole process, when, you know, the most obvious example that's in recent memory was when President George W. Bush said that we're going to treat 2 million Africans living with HIV. When we heard that, I mean, it was like the Bob Beamon, you know, Mexico City long jump, which none of the students will remember, but it was a paradigm-breaking jump that was just so much farther than anything that had ever been tried before. When we heard President Bush say that, we were just dumbstruck. We couldn't believe that he was going to try something so bold. But he understood something very powerful about how Washington works, that if you just then hand over that project to the various agencies that are in charge of it, it would never work. So he called it the President's Emergency Plan for AIDS Relief. And he got a team together to work on it that reported to him. And every time there was a bureaucratic problem, he would reach in and remove it. So when presidents take leadership and try to bypass all the different ways in which bureaucracies can slow something down, I've seen great things happen. And, you know, I think what might happen, if you look at the Massachusetts example, you know, a couple of years after the enactment of the Massachusetts healthcare law, there were lots of problems. People couldn't find primary care doctors, the costs were going up. And so that's going to happen, I think, right? If it follows the pattern, that could happen right around November of 2012. And so I'm hoping that there's enough pressure. President Obama has shown fantastic leadership on improving access. I'd like to see him, along with members of Congress, tackle cost and quality. Because if he did, I've talked with lots of both Republican and Democratic senators, and all are completely on board. The answer that I get more than anything when I say, you know, we really should start a National Institute for Healthcare Delivery. We have an NIH. We spend $30 billion. Why don't we have a National Institute for Healthcare Delivery, since we spend almost $1 trillion a year on healthcare? And most of them look at me and say, you mean we don't have that? It's hard for them to believe that we spend so much on healthcare, and some of these basic principles that other businesses use, like cost accounting, right, are not used. It's almost unbelievable to them. So we need to do a lot more in terms of educating our leaders, and what we hope is that the federal government and other enlightened souls will invest lots of money into great institutions like Dartmouth College, who can help them with their problem.
Two other constituencies that are very important. You look at the slides, they're very compelling, but if you step back, what you realize is if you're telling people or institutions that are doing 10 back surgeries per 1,000, they got to go down to 2, you do the math, that means 8 doctors and 8 patients are not doing what they do now. So how do you persuade doctors and patients who have a culture of expecting the most now at relatively low cost to them that this has got to change?
You know, the great news on that one is that a lot of people throw up their hands and say, you know, it's not possible. But there are lots of systems, like, you know, one of the ones that we taught in the master's class, Masters in Healthcare Delivery Science class, was MD Anderson's head and neck cancer group. And they went to a salary system where they, in a very interesting way, just shifted the incentives altogether. And you look at systems like the Mayo Clinic, where people are paid on a salary basis, but are incentivized to keep their patients healthy, it can work. So there's no simple answer, but the good news is that there are a lot of good places that have already done it. Now, the trick is that we got to go out and study intensively how they did it, and then offer up to healthcare systems around the country. Here are 10 models of how this was done in other places. I don't know which one will work for you, but as you go into this process, you should have these 10 models in your head very clearly. Yeah.
Terrific. Well, we will go to the audience. I believe we have microphones on the side. We'll start right down here, if we could bring a microphone up.
Hi, President Kim.
Hey.
So I have a two-part question. So the first part comes from the task shifting that you mentioned earlier. And that's been thrown around a lot, particularly in the realm of job creation, in terms of there's a lot of regulations that are built up that prevent new positions in the healthcare industry from popping up. And I was wondering, first, what your take on that is and whether you think these restrictions could be lowered realistically in the current political realm. And then just to build off Professor Whelan's question, in terms of if there isn't a presidential push and if Congress remains the way that it is at the moment in sort of a gridlock over the healthcare issue, what do you think realistically could be done to promote healthcare delivery?
Yeah, so in terms of the task shifting, it's a real issue, and it's one that we faced in Boston when I was working there. We brought the community health worker program that worked so effectively for Joseph Jun in Haiti. We brought it to Roxbury, which is a very low-income area in Boston. And we showed that if you send community health workers that speak the patient's language, you dramatically reduce the cost of hospitalization for poor patients living with HIV. Because what happens is they come to the hospital, they're really sick. We give them all their medicines, we do everything. We send them home to situations that we have no idea of. And they stop taking their medicines and they land back in the emergency room with a really severe opportunistic infection. It happened so many times. And so we simply just almost completely imported this program to Roxbury and had really positive impact. But the problem was none of the payers wanted to reimburse for community health worker outreach. So it took us 5 years to collect the data to show that this has a very strong payback, and then some of the health plans began to reimburse for it. And so now my colleague who really invented that program in Roxbury is working in Long Island and several other places where her efforts have been shown to be effective. And so it really is almost exactly like a hotspotters program, and it took a while to make sense of it. 5-10 years ago when we were starting this program, there wasn't the same kind of pressure that there is now. So, a tool has played such an important role in making, making the solution of the healthcare crisis a cool thing. These articles are all read by the White House, and so my sense is that the ease of making it possible to reimburse, for example, for healthcare worker visits is going to be, the ease is going to go up, and we're going to have a lot more programs like that. And the second part of your question, I forgot. What was that?
Just in terms of, thank you.
Yeah.
In terms of just tangible steps that could be taken in the short run.
That's why I forgot it, because it's such a hard question. What I want to emphasize is that this national collaborative is a very tangible step. Now, it's going to require some funding. It's going to require some support from somebody. But the great thing is that all these hospital systems are so intent on improving quality and lowering cost that it's going to go forward no matter what. So it's things like that, great hospital systems in the country coming together, and in this case, coordinated by Dartmouth and College and Dartmouth Hitchcock, tackling these problems and just saying, we're not going to wait for policy change. We're not going to wait for some sort of mandate from somewhere else. We're going to figure out how to do it among ourselves because it's so critical. I also think companies are really intent, that the private sector is really intent on helping us find these solutions. One of our board members, Jeff Immelt at General Electric, spends $3 billion a year for his healthcare benefits, and the costs are rising at 9% a year. Right? So for them, if we can find a way, Intermountain Healthcare could potentially reduce their cost by 10, 20, 30%. But what they're looking for is just deflect a little bit of the growth. If you can take me from 9% to 7% a year growth, that's huge dollars for them. So we think that all the pressure points are in place. And now we just have to have institutions that are bold, forward-thinking, going out there and showing, hey, look, everybody's down to 2.2. We've saved $55 million a year. This is doable. When we get there, the threat of a good example, I think, will be very powerful.
Let's go right here on the aisle.
Thank you. So there's a lot spoken about the disparity between what the U.S. spends on healthcare and the rest of the world. Are other countries just that much better at healthcare delivery, or does something else account for that huge disparity in spending?
Well, there are some countries that are better than us. If you look at just the numbers I showed you about obesity and infant mortality, they're better at us in those numbers. But it's not like they're employing systems engineers and strategists and operations specialists either. So there is a lot of waste to be taken out of just about every healthcare system in the world. I mean, every healthcare system I've ever seen in the world could function a lot more effectively. So this is really a global problem. But what they do is they have much lower costs for administration. Look, there's no simple answer in the United States. A lot of people say single payer would solve all the problems. It wouldn't solve all the problems because we see single payer systems all over the world that are still rife with healthcare delivery problems. I think that if we can take some of the administrative bloat and cost out of the system, that would be great. But there's no way that a change in the payment form or a change in a few policy or a few incentives is going to make the whole thing change. You need the better human beings that will walk around with great ideas, with skills that are not applied to healthcare, like systems engineering. You need them in every single healthcare setting. It's reimagining healthcare delivery in a fundamental way. Yeah.
Let's go right here. Sam?
President Kim, one thing we've seen in politics a lot, but you haven't mentioned at all, is healthcare rationing. We've heard it a lot for the healthcare debates last year, 2 years ago. I've seen some very compelling arguments that say we can't sustain Medicare in its current form without some sort of rationing. Is this what you think we need to be doing, and if so, how should we go about doing that?
Well, I think this has been an argument that goes back and forth and always contains a lot more heat than light. And one of the criticisms of Don Berwick, who's currently head of Medicare and Medicaid, is that he was quote unquote for health rationing, and nothing could be further from the truth. What he was saying is not rationing; we're talking about rational, right? And so let me give you a very specific example. So the current head of the Dartmouth Center for Healthcare Delivery Science is Al Mully, who invented this system called shared decision making. And shared decision making is at the core of our 2.2 surgery per thousand rate. Because what you do is you go through a very focused, systematic process of eliciting the values of patients. Right? Now, what they were finding is that you can do that, and then when the patient goes to talk to the surgeon, often they come back saying, I want surgery. I say, well, wait a minute, you told us this, this, and this, and that's not consistent with having surgery. So if you have a system where you're educating both physicians as to how to elicit the desires of the patient, and then you educate the patient on the implications of making various choices, what we see is lower cost and higher quality. So I think that's just an example of an extremely humane and effective way of reducing cost pretty dramatically, where at the same time you increase quality and increase satisfaction among patients. We haven't even begun to look for all the ways to reduce costs in healthcare using those methods. So the notion that we have to sit back and have death panels or rationing, I think is pretty far away from where the real experts in healthcare have been talking about. So you've seen the numbers on just one problem, back surgery. If you did the same thing with prostate surgery and all these other things that we think are done in numbers that are much higher than necessary, you'll get tremendous savings that we think will bring a kind of rationality to the system that doesn't put you in terrible situations of telling people that they don't get the care, whereas the people who can pay get the care. We need to move there. Maybe one more question.
President Kim, I was wondering if you could speak a little bit about pilot programs, these bundling programs from Medicare and their benefits, or whether or not they could be realistically implemented on a larger scale.
The bundling programs?
Where Medicare would possibly pay hospitals for
accountable
a
care.
Set amount.
Right, accountable care organizations.
Yes, exactly.
I think it's a great idea. It has tremendous potential. Again, you know, we should be very proud as a community. Probably the most articulate proponent of that idea is Elliot Fisher, one of our own faculty members. And I think it's a tremendous idea that has tremendous potential. I think it's one solution among many that we'd have. Even if we were to implement the accountable care organization idea across the board, I think there's still a need for those better human beings taught in different ways to make those things work really effectively. But it's an extremely promising idea. Elliot Fisher, Mark McClellan, the former head of Medicare and Medicaid, have been the most articulate proponents of that approach, and I think it's a great idea. Yeah.
So we are at 5:30, so we're going to draw to a close, but I have the final question.
Yes.
And one of the things we've established this summer, since it is a lecture series, is we've established a custom where each speaker gets to ask a question of the next speaker. Unfortunately, we did not get Treasury Secretary Geithner to ask the president of his alma mater a question for you, but we're going to resurrect the trend here. Next Thursday, this is also a way of forward promoting lectures. Next Thursday at this time, we have Buddy Roemer coming to campus. Buddy Roemer was former governor of Louisiana, Democrat turned Republican, who is apparently going to be seeking the presidency. That announcement's supposed to come soon and may come when he's here. So we have asked Governor Roemer to address or provide an economic roadmap for the middle class. How is he going to deal with the median wage that seems to be stagnant and provide a better future for folks who really feel like they're running in place in the country? So pursuant to that theme, do you have a question that you would like to send to Governor Roemer?
My first question would be, why on earth would you want to run for president of the United States? But more seriously, I think the Republicans have been very critical of President Obama's health care plan. But I'd like to hear what their plan is. I mean, how can you be, if the one thing that's going to break the bank is not Medicare, is not Social Security, but is Medicare, Medicaid, which everyone agrees on, then in addition to critiquing the Obama health plan, which I have myself, what's their plan? I would love to hear it. And I think if candidates these days are just running on very weak platitudes about health care, I think we should worry.
Great. That'll be the first question next Thursday. Thank you very much
for
sharing your time.
Thanks very much.